Welcome to HMA's Vital Viewpoints on Healthcare, concise conversations with experts that identify practical solutions to make healthcare and human services work better. I'm your host, Jennifer Colamonaco, and I'm thrilled to be your guide as we explore new ideas for solving challenges that confound our uniquely American systems charged with delivering health and healthcare. Kevin Kirby has more than 25 years of experience with Medicare reimbursement and extensive Medicare Part B expertise, particularly relating to pharmaceuticals and biotechnology. Kevin joined the Moran Company, which is now an HMA company, after serving as legislative counsel at Pharmacia and Upjohn. Kevin was active in policy development for clients interested in issues that were affected by the Affordable Care Act, and he has become an expert in a variety of drug reimbursement issues governed by the Medicare Modernization Act. Kevin, thank you for being with us on the podcast today. Let's just start. How did you get started in the pharmaceutical industry? How did you end up there?
It's interesting. My first job as a high schooler really was in a pharmacy. So I started in retail, went into some policy issues during a volunteer program after college, but was also working for a pharmaceutical lobbying office as a college internship. So it's really been my whole career has had some tie to pharmacy or for pharmaceutical issues. That's kind of continued for more than 25 years, as you said.
Right.
We won't ask people to do the math.
So what part of the policy analysis part of this sort of grabbed you?
What I found early on in my career was that a lot goes into figuring out what the laws governing our healthcare system need to be, and that those policy development issues can take years. So I started in my career right around the time of the Clinton healthcare reform that generated some of the ideas that then later became part of the Affordable Care Act, but did a lot of work for multiple years on drug coverage issues because there didn't used to be a drug benefit in Medicare. And so we were working on, what would a drug benefit look like? And from the perspective of a lot of my clients, it was really important that there be some catastrophic coverage to protect people against high drug costs. And so that was something that both in the pharmaceutical company that I worked for in the mid 90s and then starting out at the Moran Company was a focal point for our clients. And we did a lot of the development that led to Medicare's drug benefit, including that catastrophic coverage, which finally is converting to a full stop loss or full cap this year.
Right. Which is interesting. We've gone quickly from not covering it all to covering it substantially, which then, of course, raises questions. I mean, we always have questions about sustainability of Medicare and Social Security. It's especially, it's kind of an ongoing concern. But as you've watched Medicare policy evolve in this space, what types of changes have had the most significant impact on the sustainability? And maybe I'll say kind of positively and negatively, right? Because there's certainly both.
Yeah, I might be a little contrarian here because in some sense, people younger than me would express surprise that Medicare didn't always cover drugs. That it seems to me is a fundamental part of health coverage is to be able to get access to prescription drugs. And I think that the way CMS and Congress administered the program, they were careful stewards trying to make sure that it was affordable. So it was a big change in Medicare at the time, but it's taken many years for the premiums that people pay to catch up to the Congressional Budget Office's original estimates. And it feels to me that what's driving a lot of the questions around sustainability for Medicare in particular is demographics. We just have a lot more senior citizens than we used to. There are real questions about how we're going to make sure to keep the promise of Medicare going. But it doesn't feel to me like adding a drug benefit or something that somebody did has created this problem. You could argue people needed to step in sooner to address some of the demographic issues and some of the things that are driving the growth. But it feels to me like there is still time to do that.
So as you've seen the Affordable Care Act and the Medicare Modernization Act sort of, be implemented, how do you think that these laws have really shaped the landscape for reimbursement? And what are companies kind of challenged with today as these laws continue to evolve?
As we've discussed, the MMA kind of created Medicare coverage for outpatient drugs. It also made some reimbursement changes for physician administered drugs to try to use average sales price to kind of bring some of those costs down. And there have been questions people have raised about, is that still the right metric, and what can be done to control those costs? And I think we're going to continue to see that evolve over time. Um, but it does feel to me like having the Affordable Care Act take a government control of more of the healthcare system, so there are more people that now are getting their drug coverage through government plans, whether it's Medicare or the exchanges. It has created more of a spotlight for the pharmaceutical industry on drug pricing issues that finally led to the Inflation Reduction Act trying to make some changes. And I think we'll continue to see the landscape evolve just as people try to make sure that we can continue to realize the value for drugs in an affordable way.
Right. Well, that's great. And that's exactly where I was going to go next. So that's all evolved. And now we have the Inflation Reduction Act, as you mentioned, which, in common parlance is Medicare gets to negotiate the price of drugs, broad bumper sticker version, right? Obviously, it's more nuanced than that. So, it's a big deal in some ways. And it seems like maybe a little bit overblown in other ways. So, how do you explain this to people in a kind of a short, understandable way to really understand the magnitude of what the Inflation Reduction Act did for price negotiations?
So I think, and perhaps I've been working for the pharmaceutical industry for too long, but calling them negotiations at this point, I think the industry has a point that they're not really. That the Congressional Budget Office for years, when faced with policies that would allow for a negotiation, said, well, no, the Part D plans are going to do better. You're not going to get savings from that. And what led CBO to first start giving savings to some of these negotiation policies was the presence of an excise tax and the presence of a government ceiling price. These are at start right now price controls. The question, to your point of whether this is a big deal or not, is going to depend on how this evolves over time and how people look at some of the consequences, unintended or intended, of the IRA and decide where they take this next. So is that a question of putting more drugs through the negotiation process, in quotes? Is it moving to some kind of reference price or launch price control, similar to the Trump administration's most favored nation policies that may or may not go forward in the future, but is those sorts of policies that CBO has said have more of an impact than just expanding the IRA as it is. So I think it's going to be interesting to watch. Obviously, when you have just 10 drugs now coming out of the gate, and some of the savings from those negotiations are difficult to quantify because they're capturing some of the discounts already in the market, and those manufacturers are exempt from some of the required discounts that they were going to be required to provide under the reformed drug benefit. Otherwise, are probably not included in some of those estimates. So it's still to be determined exactly what the impact of the act is going to be, but it does seem to be bringing drug prices down for the first 10 drugs, and then we'll see how it evolves.
So, a couple questions in what you just said. First of all, the first 10 drugs, I might be mistaken, but those are drugs that have been around for a while. Do they have generic alternatives or maybe on the precipice of biosimilars, some of that?
Yeah, so to be picked, you can't have generic or biosimilar competition yet, but you also have to have been on the market for some number of years. So it's kind of at least 9 years before negotiation starts for small molecule drugs and 11 years for some of the biotech products. And that was really the way it was designed, was to get at those products where maybe competition hasn't started yet, but Congress felt like it should. So you're trying to capture those products that are sort of have been on the market long enough that policymakers would argue that they've captured the value of their research and development investment, but haven't yet gotten generic or biosimilar competition.
So it's honed in on that. So they've had their chance to, reasonable amount of years, 9, 11 years. That's, reasonable amount of years to,
Depending on your point of view, yeah.
depending on your point of view, right? That would be my point of view, reasonable. Not, I won't put words in your mouth. So a certain set period of time to capture, and then, but before generic competition comes in. Okay, that's an interesting nuance. So, and then can you talk more about your point about how CBO views things like most favored nation? You mentioned that they view that as perhaps more beneficial in terms of saving money. Can you talk a little bit about kind of the different mechanism that would have brought into drug pricing?
So what I was referring to is they put out a report recently talking about their opinion on different ways that drug pricing policies might evolve over the next few years. And what they said was that just expanding the IRA would have a pretty small impact in, sort of the 1 percentage point. And obviously when you're talking about billions of dollars of drug spending, that's not nothing. But they said that using reference prices, whether it's an international price or something else to set the pricing different from what's happening under the IRA's negotiation, could have a more than 5% change in drug prices. And so I think the idea is probably both what the metric is, probably is sort of the universe of products. So, is it going to be a launch price thing that you're going to tie prices in the United States to other countries or something like that? So there are a lot of different ways where that could potentially bring prices down. CBO also noted that some of those things are going to have impacts on other countries, impact on research and development. So there's not a magic wand that you can wave that is just going to magically cut drug prices without other consequences.
Well, that cuts to my punchline, which I'm not going to get to yet, but I'm going to ask you about a magic wand later. So think more about that. But let me just ask, just even this conversation, obviously you can already tell there's misinformation perhaps, or perceptions that differ on, what's going to work. So based on your years of research and experience here, what do you think people get most wrong about pharma pricing and the value accrued by pharma products?
So I think a lot of the complexity of how people think about pharma pricing comes with the fact that people feel differently about healthcare. They're not evaluating the price that they pay for healthcare in the same way that, they evaluate the price they pay for their phone or their car. And there are things that the pharmaceutical industry does to bring cures to market, that their HIV is now probably a chronic illness in ways that it really wasn't when I first came into health policy. A couple of my clients are getting close to having that their drugs to treat cancer be found to be curative, and so that's really exciting. That costs money. That the research and development that goes into that takes a lot to fund and a lot to do. And so the question really is, do we want to allow people to set prices to encourage more of those investments and innovations, or is there some way we're going to treat drugs differently than other products? And you can argue from a policy perspective that there are reasons that perhaps that should happen, but the consequences are also there, as CBO and others have recognized, that you're going to get less drugs if prices are cut too far. And some stakeholders would argue that CBO has underestimated what will happen as a result of IRA negotiations. but they see an impact. The industry certainly sees an impact. So from my perspective, a lot of that is to be determined, but I think there's a need for care when approaching how you're asking an industry to set its prices, and then what happens to investment in that industry as a result.
I want to ask you more about CBO in just a minute, but let me just go back to, your point about drugs have been treated differently, right, than the rest of healthcare. From the get-go, they weren't included, then they were included, but yes, there's a more transactional piece to it because we pay separately at the pharmacy versus, I guess we somewhat pay for a lab or an X-ray or, and all of those incentives are like the levers that we use to try to, direct people to making good healthcare decisions or et cetera, right? So if pharmaceuticals have been treated differently in terms of, that they were not included, now that they are included, does it make sense to keep them sort of still on the outside of what we pay for healthcare? I mean, when we think about, some value-based payment and other types of payment reforms, I think there's always the question, are they inside or outside of the bundle? Do you think that it makes sense to keep pharmaceuticals on the outside of payment mechanisms, or does it make more sense increasingly to roll them into all the other interventions that might generate a health outcome?
It's a really interesting question. And I think one of the areas where you can see that happen somewhat is in Medicare's inpatient prospective payment system, where there are drugs that patients need when they're being hospitalized. And one of the problems that happens is if you have a drug that is particularly low volume and also is high cost, it creates an access barrier when a hospital says, well, I'm only going to get paid a certain amount for this payment bundle. And it's not worth it to me to pay for this drug. And then whatever volume of cases that use that drug isn't large enough to influence the payment for the diagnosis related group, which is the bundle that Medicare uses. So the more that you create those kinds of bundles, you're right, you can create incentives for physicians, hospitals, other providers to use the most cost effective alternatives, but you're also going to create barriers to access. And so the question is, what's the right balance in that situation? And I think it's an important part of policy development, and there's a lot going on.
I feel like that right there contributes to a lot of the confusion, and probably that's the punchline of all of this is it's complicated, right? But makes it complicated because I feel like we constantly cycle between everyone should get access, who needs access, right? And that becomes kind of a rallying cry, particularly for patient groups, perhaps rightly so. But then no one should have to pay over a certain amount because it affects people financially, right? So it's like we're kind of caught in this conundrum, price and access, right? Being I guess, textbook, probably a chart that you can draw in graduate school, right? Like, there's a line there somewhere and not everybody gets everything for a low price. So maybe let me kind of go back to the CBO analysis. And the Moran Company became somewhat famous for replicating CBO analyses around how particular policies are judged to either save or cost money. CBO is a big deal. I think I didn't fully appreciate how much CBO is a big deal in determining legislation and what moves forward in Congress. So can you just talk a little bit about like the impact of that model, I guess? And then, in your experience here, where does it over or underestimate, given its importance? Obviously, it's an estimate, it's a model. So maybe share a little bit of your insights around the impact of that model and how it's working.
Sure. Well, so one of the things that the founder of the Moran Company always said was that the secret to successful forecasting was to forecast often. And so in working around CBO issues over the years, we've been really humble about our ability to get it right. And we understand that the pressures that they're under, they can't operate like a university research think tank. There's not enough time to get everything done and be fully careful. So what they're trying to do is give Congress the best estimate they can of what the impact of particular policies is going to be, because they're decisions you have to make between what you want to pay for one thing versus another, and how we structure ourselves. There also are really complicated responses to pieces of legislation that can change um, what the impact is. I mentioned earlier that premiums in Part D haven't really hit the points that CBO thought they were going to hit. Part of that is because of the response that the plans made, that instead of taking manufacturer rebates and reducing the cost that people pay at the point of sale, they took all of those rebates, or most of them, and applied them to the premiums that they were charging to their beneficiaries. So they were able to compete by keeping premiums down. Can you say, well, CBO got that wrong, or was that just that the market evolved differently and that there was a reasonable chance that somebody could have gotten out of the gates competing on the price at the pharmacy counter, and then things would have been different? So there are always those sorts of decisions that you make a reasonable choice, but then, if that ends up being wrong, then your forecast is going to be wrong. And I don't know that there's a way to get around that. So I think it's just a question of trying, as CBO does, to continually improve what they're doing and get things right. And I do think they get it right more often than not.
Maybe circle back to this issue of, pharmaceuticals, can sometimes save costs elsewhere in the system, right? That's sort of a promise. You slow down the progression of a disease early on, it saves money in the long run, or perhaps it offsets other types of care that might be needed if you weren't taking the medication. It seems like the data on that front haven't been strong. And maybe I'm wrong about that. Correct me if I'm wrong, but I'm curious your thoughts about, where you see evidence being amassed around that sort of cost savings trade-off. Um, and, maybe why it hasn't. Is it that we're not able to collect the data, or is the data haven't sort of proven their point? Thoughts on kind of measuring the cost savings trade-off of pharmaceuticals?
You're right that the data, those arguments have been made for many years, and for many years, CBO wasn't willing to recognize them at all. In the last several years, they have started to allow some offsets for policies that improve prescription drug adherence, on the theory that they were convinced that there was evidence that brought these things down, but it's not a dollar for dollar thing at all, and it just is an assumption. So it really depends on the spending in other areas for particular types of patients, and then how much adherence you're able to draw there. You've seen with the obesity drugs that CBO, sees some credit for some of the things that are happening to other healthcare spending, but it's still that the drugs themselves are going to outweigh some of those offsets. Some of it is a data question, and some of it is, that there can be real benefits, and that there's also even a darker element. If you have a drug that cures cancer, you've got people living longer and spending money on other parts of Medicare. So if it while somebody's young, it keeps them in the workforce, and that they're positive benefits to the budget that happen there. I don't think anybody would argue that we don't want that cure for cancer, but it is going to continue to cost money.
Yeah, that is kind of the dark but important underbelly of some of this analysis. Um, you mentioned the obesity drugs. I guess if you think about it, just as a averagely informed person, right? If you can take medications earlier in your life to avoid obesity, you avoid downstream negative effects of obesity, right? Anything that's preventing something or capturing, reducing the impact of a disease early on is going to have downstream effects. But how does that work with, CBO's estimating Medicare costs? Obviously, you don't get into Medicare until you're 65. So you take a drug when you're 40, somebody else is paying for that, right? Medicare is not paying for that. So, when they assess the impact of GLP-1s, for just as an example right now, Are they only looking at the expected cost savings of, to Medicare, or are they kind of modeling the overall cost given that somebody has to be paying for those right now? How does that factor into their estimates around those drugs in particular?
So they're modeling against a baseline of what otherwise is happening in the system. So a policy that expands coverage in Medicare isn't going to get credit for the savings when somebody is younger unless it's making changes to encourage more use of a product when somebody's younger. But how the score turns out really does depend on what the policy is. um, so CBO has said that something that just takes obesity drugs and covers them in Medicare could end up costing $35 billion. At the same time, we've heard reports that more limited portions of limited versions of the policy that say would provide coverage for people that already had it when they were younger before they came to Medicare would be far more limited. So some of those trade-offs are there. Because to your point, if you're fully realizing the benefit of the products by continuing them for patients that were already taking them when they're younger, maybe you're getting, you know, more of the benefits for the Medicare program to keep that going forward.
Are they estimating? I mean, most of that's happening in commercial coverage, right? I mean, I'm sure some Medicaid, but is there a place where they're estimating the overall impact, or is that coming more out of universities and research, academic think tanks?
So CBO tends to be focused on what they're being asked to score. So they may have some background research that they're doing on the overall benefits to be ready to consider things that might require employers to cover it, because there are things that flow into tax revenues and ACA subsidies and that kind of thing. So there are impacts on the federal budget or policies that require coverage. But some of the benefits of the products, being taken now under current law would just be considered part of CBO's baseline. And so then when they score a policy, it's a question of what are we changing relative to what's in the baseline.
So we're not necessarily looking to CBO for some of those macro. I mean, if it's a piece of legislation that has been submitted, it's in their domain, they'll score it. But there are presumably other places that are looking maybe at more macro impacts.
Yeah, I think that's right. I think CBO certainly has research and reporting that it uses to inform its scores on the macro benefits, and some of that is part of the papers that they've put out. But I think you're right that you'll want other researchers that if you're trying to consider these things more broadly.
When we look at a lot of these innovative drugs or curative drugs, it seems like part of the problem is that we have a really good mechanism to understand their impact on particular programs, as we just talked about. But there are drugs that the benefit accrues much later than whoever pays for it. So commercial employers are going to pay for drugs that might be high cost that have a benefit to Medicare down the line. And is there a world in which you see policies emerging, for perhaps curative drugs or really high cost genetic therapies where it almost becomes like a new funding mechanism, something where, maybe the government pays for it, even though it's not technically in Medicare, but we know that Medicare is going to accrue benefits in some way. I've heard that, discussed over, I don't know, it's probably been 10 years and it hasn't exactly happened. But do you have any sense that there could be some innovative policies around how do we pay for really high cost, but really critically important therapies?
You're right that there's been a lot of conversation about that for cell and gene therapies, and particularly some of my clients that are manufacturers of CAR T cell therapies, because particularly before patients get to Medicare, and even in Medicare, if they're on one Medicare Advantage plan one year and move to another the next year, the plan that pays for these expensive therapies might not always be the one that benefits. And so there are people that think through, is there some kind of unique financing mechanism? Like, can you have a bond or something like that that funds the payment for these things, and then each payer picks up, their share of this as the patient carries it forward. Um, so you're right. There's a lot of thinking that's going into how can we spread the cost of these things across all of the different payers, whether it's Medicare or private payers that benefit. There are a bunch of good ideas out there. None of them have really emerged as, this is happening now, but I think it's a great question for thinking through how we're going to fund some of these curative therapies in the future.
Is there anything to learn there from, I'm thinking like surgical techniques or surgical tools that have changed how, survival rates for particular surgeries or things? Are there any, as a researcher, I guess, are there any places where you would look for ideas, or are those just so different from pharmaceuticals?
It's a good question. A lot of the innovations that happen in surgeries and things that involve hospitalizations bring down some of the costs to hospitals over time, and so they use that to figure out how to better provide care within bundled payment systems. So there are incentives there, exceptions to that when you get to capital costs and funding, different MRI machines and that sort of thing. But I do think that the challenge of some of these cell and gene therapies and the cures they represent is a different category of problem.
Yeah, that's interesting. Let's just quickly talk about the issue of 340B pricing. And like, we're down now in the weeds of like people who know the lingo here, right? So, but if you're anywhere in the pharmaceutical space or in the health system space, you know that this is an issue. So, can you break this down? What's the basic issue, and what are the real challenges that pharmaceutical companies face when navigating this arena when it comes to Medicare benefits?
So the 340B program, which is named after a section of statute.
Not a very creative name.
No, but it was designed to provide discounts to certain safety net entities that had been getting discounts before Medicaid rebates went into effect. And then when the Medicaid rebate program was started, because of the way it was structured, it presented a real disincentive to continue providing discounts to these safety net entities. And so Congress stepped in and said, we're going to make a program so that these people can get discounts without driving up the manufacturer's rebate costs in unintended ways. So I think that was a deal that worked for people for a while. And then as hospitals started to try to leverage the program to expand, the patients that were in theory getting the 340B drugs and getting access to the discounts, the program really began to grow. And in particular, using contract pharmacies outside the hospitals has, brought this discount, I think, my pharmaceutical manufacturer clients would argue, beyond the scope that Congress initially intended. And so the question is, what is the appropriate scope? And then as the program gets more complicated, how do you deal with problems of duplicate discounts and other issues? Because the manufacturer is not supposed to pay a 340B discount and a Medicaid rebate on the same prescription, but they know that happens. How do you stop that? Um, they're not supposed to pay a 340B discount and an inflation penalty on the same prescription for some of the things that the IRA has just recently implemented. How are you going to deal with that? And so there's a lot of really good questions about how 340B evolves, how you give HRSA, the agency that administers it, do they have the right authority to issue regulations to clarify some of these questions? It's an area that needs further policy development. And right now you see that happening with, people fighting things out. But I also think that there are conversations happening among stakeholders to try to think through, okay, what is the right solution? And I think some of our HMA colleagues are, convening alliances and doing things that um, really could help move the ball on this issue.
So it's a big deal for pharmaceutical companies, and do you see it as a point of leverage? And, they want this fixed because it's not working as it was intended. So in order to it's one of those, like, you open the box, right? You open the policy box and say, okay, let's fix this. But does that then open the box to fix other things? So, yeah, I mean, I know the discussions have been going on, which is probably why they haven't been solved yet, because it's complex. But, do you see this getting resolved soon? And what kind of trade-offs do you think they may have to make in order to fix this?
So it's one of those issues, much like the Affordable Care Act came in, how much, 20 years after the Clinton healthcare reform efforts, that people have been looking at for a long time. And I'm not sure that I'm a good enough forecaster to predict when that logjam is going to break. Because it always seems like, okay, this might be the year, but there's so much complexity that so far it hasn't been the year for any of these reforms. So the question is, at what point does a consensus emerge, just as it did for the ACA and the IRA? Is there a point where there's enough of a consensus on how we can do this that Congress will act? I would suspect that probably, we're still another couple of years out, but I've been wrong about how fast consensus emerges in the past.
Well, it's always slow, 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 and then all of a sudden really fast. So it is often hard to predict. So I want to ask you the magic wand question. You mentioned there are no magic wands, but if you had one, given your extensive background and your knowledge of lots of the complexities here, what legislative or regulatory changes would you recommend to improve how Medicare is able to kind of strike the better balance of, pharmaceutical pricing, managing the costs of medications, and the need to continually innovate in therapies and new therapies and treatments?
And I think the magic wand would probably go back to something you said earlier about, like, we're not doing a good enough job of measuring the value of some of these interventions. And so could you create perfect data? Because I think that a lot of why we're not doing a good job with setting up value-based agreements and other kinds of value-based care is that there's legitimate disagreement about how you measure the value of some of these interventions. Until you can create full transparency on all of the different ways that a product can create value and all of the different people that are going to benefit from that value, it makes it challenging to then decide how you base an agreement on prices to deliver that value. So I think that everybody wants to have some kind of system where we pay for only the things that work and not the things that don't. But without perfect data on what it is that works and doesn't, it makes it really challenging.
Do you think we're getting closer? I mean, I feel like so many things have happened around data transparency and data liquidity and all these other things that our colleagues talk about, but are we really getting closer to being able to better measure these outcomes?
I think that the data are improving, and I think that the way that different stakeholders in the system are thinking about them are improving also.
This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription-based service that provides state-level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up-to-date RFP calendars and state-by-state overviews, HMAIS has all the information you'll need to power your initiatives to success. This podcast was produced by myself, Jennifer Colomonico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.